So my name is Stephanie. I'm an M4 at the Carver College of Medicine, University of Iowa. Today I developed a case presentation on vaginal discharge and sexually transmitted infections, which I think is a really important topic to review. This is something that you'll see a lot in primary care specialties. Especially, I'm at the university, so I'm around a lot of the college students as well. And so this is a very appropriate topic to review if you're thinking about treating that kind of population or just the general population overall. So let's get started. So you guys should have access to, oh, looks we have somebody else come on. Hello, Diana, welcome. You guys should all have access to the, what is it, the Google link? Yeah, the Google Drive, the link for the soap note. And if you don't, just let me know and we can get that to you. Okay, so as always, we'll do the case. We'll go through some of the important findings like the physical exam, the differential diagnosis, assessment and plan, and then learn a little bit about the pathology of the disease that we are reviewing. All right, so let's start with the case. So your patient, our patient, is a 19-year-old female named Abigail. She's presenting to student health with concerns of vaginal discharge and odor. Looks like we had somebody else join as well. So hello to people joining. Okay, so this is our chief complaint. We've got a 19-year-old and she has vaginal discharge and odor. So what are some questions to consider, just knowing this? Like we said, how long has the discharge occurred? Yeah, so some details, right? Some more details about the symptoms. That's great. What else? What does the discharge look like? Yeah, more about the discharge. I think that that's a great question to ask. So ask her to describe the discharge. How long has it been occurring? What does it look like? Maybe if there's any associated symptoms, things like that. So kind of running through our general history questions about a chief complaint, which the mnemonic is old carts. And I have a picture of that on the side here. So asking about onset, location, duration, character, if there are things that make it worse, if things that make it better, the timing of it, like how often does it occur throughout the day, and the severity. And does the severity wax and wane? Is it pretty constant? All of those things. So besides asking about the chief complaint, like the general history questions about that complaint or concern, I guess I should say. I don't like to use the word complaint these days. I like to just say like a concern that the patient has. What other things do you want to ask? Past medical history is a huge one. Yep. Going a little bit deeper into that, so medical conditions that she might have, chronic medical conditions, but what else? Is there any other aspect of the history? Yeah, family history. Family history is big. Any other history that we normally take that might be pertinent in this case? And that's pertinent in every case, but social, yeah, so social history, right? And diving even a little bit deeper, like maybe sexual history, right? So, with patients that can be, I think, especially as a trainee, that can be uncomfortable to talk about at first. And so it's always important to start by saying, like, we ask all of our patients this questions, if any time you feel uncomfortable, you don't have to answer. This will help us reach a diagnosis and help us learn a little bit more about what's been going on so that we can take care of this problem. So always making sure to to be kind and to make sure that the patient feels comfortable asking those questions. So, okay, good job, guys. All right, so does anybody want to read this, the rest of the case details? If not, that's fine, I can. Okay. So, Abigail reports the vaginal discharge and itching began about a week ago. The discharge is milky white in color, has a fishy odor to it. There's mild itching to her vulvar area. She doesn't have any abdominal pain or pelvic pain. She doesn't have any burning with urination or no urinary frequency. And she doesn't have any hematuria or blood in the urine. She's sexually active with one male partner. It's her boyfriend. She's had this boyfriend for 3 years. States he was recently tested for sexually transmitted infections at an annual physical, and apparently he was negative at that time. She denies using new laundry detergent or new underwear. She has been making sure to clean her vaginal area after sexual intercourse. Okay, so we got a little bit more information. Past medical history, no chronic medical condition. She broke her left wrist during gymnastics practice when she was 8. For social history, she's a college freshman. She's majoring in elementary ed. She has a boyfriend of 3 years, as we said. He's her only sexual partner, and they are in a monogamous relationship. She denies smoking or alcohol use. For family history, her mom has hypothyroidism. Dad has type 2 diabetes, and she has 2 older sisters who are healthy. And if we need to go back to these slides or this information at any time, we can. But let's pause for a minute and talk about vaginal discharge in general. So this is a question for y'all. Is vaginal discharge normal? Like, is it something that happens normally? Yeah, exactly. Vaginal discharge is normal. Yep. So it depends on the presentation, but generally, yes, vaginal discharge is normal. So it's a mixture of skin cells, bacterial flora, mucus, fluid, and basically helps to lubricate the vaginal tissue and protect against infection. So when you're a woman who has not yet undergone menopause, when you're a premenopausal woman, you usually produce about 1 to 2 teaspoons of vaginal discharge a day, and that's seen as normal. Normal vaginal discharge, its appearance, it appears thin, sticky, elastic, but its color and texture can change throughout the menstrual cycle. Signs and symptoms, though, that should prompt further investigation or should prompt you going to your primary care physician are if you have a change in odor that's noticeable, or like a marked change in color, like if your vaginal discharge is normally, certain colors and now it's like green or it's pussy. If there's a change in texture, it's like cottage cheese-like or foamy. If there's bleeding or spotting that's not the menstrual period, that can be an indication that something else is going on. Or if you have like accompanying itching, vulvar pain, or abdominal and pelvic pain with your discharge. Women when they're undergoing their menstrual cycle, or I guess individuals who have uteruses, because not all individuals with uteruses are identified as women, but you normally do experience some abdominal and pelvic pain. But it's important to ask your patients, like, is this out of the ordinary, right? Is this worse than the ordinary? And usually people know, right? Usually you could tell if things are worse than your normal menstrual pain. Okay, so physical exam, walking through this a little here, it looks like vitals are relatively normal. Heart rate of 85, respiratory rate is normal, blood pressure is pretty normal, doesn't have a fever, and she's sitting well on room air. Looks stated age, she looks comfortable, she has moist mucous membranes, everything else, lungs clear to auscultation bilaterally, so they sound good, no crackles or anything like that. and cardiovascular system, regular rate and rhythm of the heart, no murmurs, and then the abdomen is soft and non-distended, so there's no tenderness when you palpate it. So overall, pretty normal. However, what other physical exam is indicated for our patient? Any thoughts? Let's see. So she has vaginal discharge. Have we examined the vaginal area or the pelvic area at all with our exam yet? No, right. And so, yeah, a pelvic exam is an important, or is indicated in this case. Again, always asking the patient if they are comfortable with that, but this is, important to give us clues into what's going on. So let's quickly review some of the female reproductive system anatomy. So over here in the middle is like a sagittal view, like if you were just to cut through the abdomen. So this is the rectum, and then here is like the spine back here. So this is more anterior and this is more posterior. So you're looking at it from the side. Here's your bladder. And then here is your vagina, vaginal canal. Right here would be the cervix leading into the uterus, right? So uterus kind of like sits a little bit over the bladder, and some people's uteruses are like positioned a little bit differently, but typically this is how it looks. So yeah, the main parts of the internal parts of the female reproductive system is, again, the vagina, the cervix, and then the uterus. But then outside here, and here if you can imagine like let's see, like a woman giving birth. So like her legs are in stirrups. Like this is the kind of view you would see, where this is the anus, this is the clitoris, and then this is the two labia, the labia majora and the labia minora, and then the vaginal opening. That's kind of the view that you would see. Let's see here. So all of this together, though, all of this tissue is known as the vulva. So when we say like vulvar itching, it can be any of that tissue here that can have like excoriations and such. Okie dokie. Next slide. So looking a little bit more closely at the uterus and the vagina and the cervix. So here we have the vagina that leads up into the cervix, and the cervix area is actually like relatively small. So this is the canal. This is known as the external os, or it's the external opening of the cervix because it opens into the vagina, and then the internal one leads into the uterus. So it's, relatively small. And then this area is the body of the uterus. And then of course we have our ovaries on the side. The ovaries are not in contact with these ostia here in the infundibulum, but they're relatively close. So then when we release eggs, the egg can then travel, into the uterus that way. All right, so knowing that and having that background, how do we perform a pelvic exam? So there's traditionally two parts of a pelvic exam. So one is called the bimanual exam, and this is where you're just using your hands to feel the organs, and it's performed to assess the internal pelvic organs. So basically you insert two fingers into the vagina, and then you use the other hand to place pressure on the belly, and you use it to palpate the uterus, to palpate the ovaries. In my OB-GYN rotation, we did this a lot. I can't say that every time I was able to palpate the uterus, But, with practice, it gets easier, and they really know what they're doing. So, and of course, make sure you put jelly on the gloves and everything before you insert the fingers. And then the other part of the exam is the speculum exam. And so this is where you open the walls of the vagina and you can look at the vaginal canal as well as the cervix. And so again, this is from the side, but again, this picture is like pretending, we're back here. It's that same view. Like if somebody was in stirrups and their legs are apart and you were looking in, you put jelly on this speculum, this tool, and you use it to open the vagina and hold the walls of the vagina away from the cervix. And this allows a very good view of the cervix and of the canal in general. And so, and it's really deep, you have to go pretty deep and sometimes look around because people's cervixes are, positioned a little bit differently. Okay, so that's the pelvic exam. So we did that with our patient, and here were our findings. And so again, this view is that same way, like this is the speculum. So we're looking at the cervix here. We're looking at the walls of the vagina and then the cervix here. All right, so externally, when we did our pelvic exam, we see some mild erythema or mild redness of the vulva tissue. The labia majora and minora are normal with no noticeable swelling, bleeding, or discharge. The hair distribution is normal and there's no clitoromegaly, or the clitoris is not enlarged. Internal findings, and this is where we did our speculum exam. The speculum exam reveals a thin gray-white discharge from the vaginal canal. The bimanual exam is normal. We know it had no uterine or cervical motion tenderness, which just basically means when we put the fingers in and we used our other hand to push on the belly, the patient didn't experience any pain or tenderness. White discharge surrounds the cervix, but there is no discharge noted coming from the cervical os, okay, or the opening. And so this is important. I think you guys should keep in mind that from our findings, the key takeaway is that there's this discharge we noted from the walls of the vagina and the vaginal canal, and it surrounds some of the cervix, but it's not coming from the cervix itself, okay? So you use a swab to collect a sample of some of this fluid, and then we're going to analyze it. Okay, so taking a step back before we go further and we talk about the analysis, I want to go over the differential diagnosis for when somebody presents with vaginal discharge. So vaginal discharge is pretty nonspecific, and it can include infections of the vagina itself or of the cervix. And those are different. Those are different, and it's important to distinguish between them because they have different causes. So infections of the vagina are often termed vaginitis, which is also, a name for inflammation of the vagina. These can cause itching, irritation, discharge, odor, all that stuff. They're commonly caused by three main things. So trichomoniasis, which is actually a sexually transmitted infection. Gardnerella vaginalis, which is a type of bacteria. It's actually a normal bacteria flora in the vaginal canal, but this is just an overgrowth of it. And then Candida, which is a yeast infection. And we're all kind of familiar with that, quote unquote, the yeast infections that, many of you guys maybe have had them before. Sorry if that's a little TMI. I just mean like it's very common for women to have yeast infections, at least once or twice in their life. And so that is something that's termed yeast infection, but it's actually, Candida is the type of yeast. So infections of the vagina or vaginitis are less likely to cause serious consequences than infections of the cervix. So when we go to infections of the cervix, this is also known as cervicitis. It's inflammation of the cervix, and it can be asymptomatic. So it's more often asymptomatic than vaginitis is. But you can have pain during sex. You can have postcoital bleeding or bleeding after sexual intercourse, and then of course discharge. This is caused by your typical STIs, so chlamydia and gonorrhea. And the way to differentiate cervicitis from vaginitis is that the cervicitis will have actual like discharge from the cervical os, from the opening of the cervix. Whereas vaginitis will just be like from the walls of the vagina. There will just be discharge around the cervix, but not necessarily coming from the center. So, and this kind of just exactly what I just said. So cervicitis, we have this like red, inflamed, friable cervix on exam, on speculum exam, and you'll note this like discharge. But then vaginitis over here is just when you see like the fluid in the walls of the vagina. So not coming from the cervical os. And here are the 3 different types we talked about. So that yeast infection, that common one that women get, appears like a thick cottage cheese discharge. Trichomoniasis, the sexually transmitted infection, as like a yellow-green frothy discharge typically. And then bacterial vaginosis, which is the term for this vaginitis caused by the bacteria Gardnerella vaginalis. It's like a thin off-white discharge with a fishy odor. So like, how do we differentiate between these things? So we do something called a wet mount. So when you do a vaginal swab, like we did with our patient, you'll put it on the slide and look at it under the microscope. And if you see things called clue cells, which are just these like cells with this fuzzy border, that's indicative of Gardnerella vaginalis or bacterial vaginosis. For trichomoniasis, you'll actually see the organisms, the motile trichomonates. You'll actually see them on the slide. And then Candida, as it's a yeast, you can see it's pseudohyphae. And there are other tests you can do as well, but we will talk about those when we get there. And then for cervicitis, if you're concerned about, a gonorrhea or a chlamydia infection, you'll need to do a PCR, a DNA test. Okay. So looking at all of this, the differential for this vaginal discharge, what is number 1 on your diagnosis for our patient and why? Any thoughts? Bacterial vaginosis. Yeah, from the discharge color, right? So the color, great. So what else? What about like the exam? Is there anything on the exam that might clue you into vaginitis versus cervicitis? And I can go back to our exam findings. So what clues us into that this is probably vaginitis and not cervicitis? No discharge from the cervix. Yeah, exactly. So we noted this fluid and this discharge around the canal, and it does go around the cervix as well, but it's not actually coming from the cervix itself. So yeah, overall, like the picture seems to fit mostly this bacterial vaginosis, which is caused by Gardnerella vaginalis. Okay, so how do we come to that diagnosis with studies? So what we do, I'd already talked a little bit about the vaginal swab. So in clinic, yes, normally we'll just take a sample. Well, if somebody's like has concerns for vaginal discharge or, a weird odor down there or something like that, we'll just take a sample when we do the exam. And then we put it on a slide and we look at it under the microscope. And so this can tell us the difference between, or the different kinds of vaginitis. So bacterial vaginosis, I talked about these clue cells, which are just basically cells from like vaginal tissue that are studded with like these fuzzy borders, because they're holding on. Well, we'll see it on the other slide. Actually, I have a better picture of it on the next slide. Trichomoniasis, you'll see, then this isn't the best picture, but you'll see motile organisms. So you'll actually see the trichomonads on the slide. And then vaginal candidiasis or candida, or the yeast infections, are these pseudohyphae. So for bacterial vaginosis specifically, it will be positive for what's called the whiff test. And I've actually done this in clinic. It's kind of interesting. So what you do is you take some of that sample and you add like 1 to 2 drops of potassium hydroxide, and you just kind of like whiff it, you kind of just, you can't see me because my camera's not on, but like you make that motion, with your hand to kind of move the air around your nose, you like whiff it. And if it gives you like a fishy odor or like an alkaline odor, or sorry, an amine odor, then that's indicative of a positive whiff test and bacterial vaginosis. Trichomoniasis and candida obviously would be negative for the whiff test. And if you weren't sure if this was vaginitis or cervicitis, it doesn't, well, even if you are sure that it's, I think it's maybe bacterial vaginosis, it's still best practice to also send in, especially if it's a sexually active young adult, to send in a nucleic acid amplification test for chlamydia and gonorrhea, just to make sure that is not also either co-occurring or that's not the problem, right? Because when we have sexually transmitted infections that go untreated, that can lead to lots of complications down the line. Okay, so here were the results of our patients' studies. So we took the vaginal swab specimen and we put it on a slide, and then we saw this. And so these are called clue cells. So they're vaginal epithelial cells, and they have a stippled appearance and fuzzy borders. And that's from bacteria adhering to the cell surface. Okay, so all of these little study borders around here are bacteria that are adhering to this epithelial cell that comes from the vaginal wall. And this is a hallmark of bacterial vaginosis. So when you see clue cells, that's pretty sure that you have BV going on. But we also did the whiff test, and the whiff test was positive. And then we also measured the pH. The pH was greater than 4.5, which is also consistent with bacterial vaginosis. And I guess I didn't go over this on the original slide, but yeah, the pH being greater than 4.5 is indicative of bacterial vaginosis versus trichomoniasis, and candida or yeast infections will have a normal pH. So ours had greater than 4.5, and then we sent the chlamydia and gonorrhea tests off for testing for PCR, so we're awaiting those. And then we also did a urinalysis and a pregnancy test, just because, sometimes when people have discharge and they have, itching down there, whatever, you want to make sure they don't have a urinary tract infection, but both of those were negative. So you guys were right on the money there. This is bacterial vaginosis. And bacterial vaginosis, let's talk about it a little bit, because it is actually the most common vaginal infection in women. I know I said yeast infections are very common, but I feel like it's the one you hear about the most, especially because the discharge becomes like really creamy and cottage cheesy, whereas bacterial vaginosis, the discharge isn't as different. It's just the odor and things like that. So most common vaginal infection in women, and it's caused by a gram variable rod called Gardnerella vaginalis. It can also be caused by other bacteria that are normal flora, but it's most commonly this one. And the pathophysiology of how it occurs is that it starts from your vagina having decreased colonization of lactobacilli, which are like your normal bacteria flora that basically prevent other bacteria from like overgrowing. And so when you have decreased colonization of this lactobacilli or the quote unquote good bacteria, that leads to an increased pH, which causes overgrowth of other bacteria like Gardnerella vaginalis. So, what causes us to have decreased colonization of lactobacilli? Certain activities. So, activities that disrupt lactobacilli colonization and increase the risk of BV include sexual intercourse. So even though this is a risk factor, that doesn't mean BV is not, it's not an STI. So it's not referred to as a sexually transmitted infection, although intercourse is a risk factor. Having an IUD can be a risk factor. Cleaning your vagina can be a risk factor. So I think if you guys recall from earlier in the case, the patient was, she said that after she has sexual intercourse, she makes sure to clean her vaginal area. That can actually be a risk factor because it can disrupt the growth of the lactobacilli and then cause, Gardnerella vaginalis to overgrow. And then pregnancy can be a risk factor. So clinical features, similar to our patient, gray, white, thin vaginal discharge with a fishy odor. The fishy is very, quote unquote, it's like a hallmark symptom. You can have itching and pain. It's less common than the other causes of vaginitis, but it can be experienced. And the way that you diagnose it, bacterial vaginosis, is 3 of the following criteria must be met. So you have to see those clue cells on wet mount. That can be 1. The pH can be greater than 4.5. Your width test positive, or on exam you see that thin, homogeneous, gray, white, or yellow discharge. So you just need 3 of the 4 to make the diagnosis of bacterial vaginosis. So this is just a review slide to differentiate bacterial vaginosis, which we just spoke about in length from trichomoniasis in Canada. So again, the pH is greater than 4.5 in both of those, but the appearance is different. Canada, of course, is going to be a normal pH. You'll see pseudohyphae. Here you'll see the organisms again, and then here you got the clue cells. Okay. So bacterial vaginosis in asymptomatic individuals are individuals where, it's not that big of a deal. They're not too concerned about it. It's not disrupting their life. You can pretty much just reassure them. It can resolve without treatment. However, in patients that are symptomatic and it's really getting in the way of things, you can use oral or intravaginal metronidazole or clindamycin, and these are 2 types of antibiotics. If you choose to use oral metronidazole, you need to tell the patient to avoid alcohol. This is because oral metronidazole can cause something called the disulfiram-like reaction. It basically causes like redness, diaphoresis or sweating, hypotension. It's just not good if you combine it with alcohol. So while the patient is taking that oral medication, you need to tell them to abstain from alcohol. So besides telling the patient to avoid alcohol, if we prescribed her oral metronidazole, what other counseling might you want to provide to her? This is kind of guess what I'm thinking, so I apologize, but how about like thinking back to like some of those risk factors for bacterial vaginosis? What are some things that she might be doing that put her at risk that she could change? Any thoughts? Possibly avoid sexual intercourse? Yeah, I mean, I think that it's important to know that sexual intercourse is a risk factor. I don't think she necessarily needs to avoid it, but maybe when she's has bacterial vaginosis, it's something that she could avoid just because of all the symptoms until things are cleared up. But yeah, just knowing that it's a risk factor is important. What other risk factors could she change? Maybe something that she's doing that could put her at risk besides the sexual intercourse. And go back to the risk factors here. Yeah, cleaning after intercourse, exactly. Yeah, that was a small detail that she had mentioned at the beginning of the interview. Oh, I make sure to clean my vaginal area after I have sex. And that actually can lead to putting you at risk for bacterial vaginosis. And so we're not talking about like cleaning the vulvar area here, but actually just like actually flushing water or a cleansing solution into the vaginal canal. That should be advised against. All right. Great. All right, great. Yep. Interestingly too, vaginal washing can increase the risk of unplanned pregnancies because it can push the semen through the vaginal canal. Okay. So, her sexually transmitted infection results, so the gonorrhea and the chlamydia, remember we were waiting for those. They ended up returning negative. But let's picture like a different scenario, okay? So let's suppose that when we took the vaginal discharge sample and we prepped it on wet mount and we looked at it under the slide, it didn't have any results. Like there were no clue cells, there was a negative whiff test, no motile organisms, no pseudohyphae. So let's say we like pretty sure that this is cervicitis and not vaginitis. Would you want to place her on an antibiotic while you wait for the results of the chlamydia and the gonorrhea? What do you think? Or like, would you want to put her on an antibiotic that treats chlamydia and gonorrhea while you await the results? If you're sure, if you think that that's what could be going on. No, I wait for the results. Yeah, no, I think that is a great point, and it's a great guess. Our common practice is to, I mean, if you're not sure and you're like, oh, I think this could be bacterial vaginosis, certainly it's going on. I don't know if there's a coexisting infection, maybe you can wait. But if patients are at high risk for having an STI and, you're pretty sure that's what's going on, you actually want to put them on antibiotic right away. And that's just because there is concern for the consequences, the sequelae of untreated sexually transmitted infections. So again, it really is all dependent on whether or not you think the patient is at high risk. So for her, originally when we had these results of the bacterial vaginosis, we're waiting for chlamydia and gonorrhea, but we have low suspicion that she has an STI, so we're not going to put her on an antibiotic for the chlamydia and gonorrhea. Yeah. No, thanks for your thought. Yeah, so but if the situation was different, if she was assumed negative for vaginitis and we thought she was, at high risk for an STI, we would put her on an antibiotic. Some of them include, azithromycin and doxycycline, which would cover the gonorrhea and the chlamydia. Okay. So, and the reason being some of the sequelae, one of the most important and feared complications of untreated sexually transmitted infections is something called pelvic inflammatory disease. So I'm not sure if you guys have heard about this before, but it's more common with, well, I think, don't quote me on this, but I think this is what I remember from my studies is that it's more common with chlamydia infections than gonorrhea ones. But untreated STIs, specifically untreated chlamydia, can end up causing something known as pelvic inflammatory disease. Common picture is, a patient that comes in with this horrible abdominal pain. They've been having this vaginal discharge and odor, just aching in the pelvis, some pain with sex. And they just really don't know what's going on. But doc, a couple months ago, I did have an STI. I took a couple pills for it, but then it got better, so I didn't take the rest of my antibiotic. That's usually the situation. And some of the symptoms, like I said, lower abdominal pain, abnormal bleeding. On physical exam, a buzzword or like one of the hallmark signs of is cervical motion tenderness. So if you remember when we did that bimanual exam, if you have tenderness to palpation of like the uterus in the cervical area, that can be an indication that this could potentially be going on. Additionally, having fever, having mucopurulent cervical discharge, so not just like thin and white like we had in BV, but like pussy and things like that. And the reason that this is so important to notice right away and to treat and get taken care of is it can cause infertility issues. It can lead to like scarring. It can cause ectopic pregnancy down the line. So again, just a lot of complications that we want to avoid if possible. So first thing is obviously to treat STIs, and then to recognize when this is going on and take care of it. However, the concern or the difficulty with treating STIs is that, like I said earlier, vaginitis is more likely to have symptoms than cervicitis or chlamydia gonorrhea infections. Chlamydia infections can go undetected, right? And so I think this brings up a good point that, you know, if you are having sexual intercourse, if you have a patient who is sexually active, you know, counseling them on the importance of, you know, being regularly tested for STIs, or having their partner or partners also be regularly tested. Okay, so that's all I have for tonight. You guys can take a jab at the quiz. Thanks for coming and participating.